So we'll move on to our academic program. So let's start with Dr. Anuruddha Begunasekara sir. He will be discussing. He will be doing the first viva, and Dr. Ishant will be the first candidate.
Thank you, Dilina. There's a small problem in my computer. So, Balagobi, can you share the screen when necessary? When necessary, yeah?
Yeah, okay, sir.
Thanks a lot. Shall we start then? Candidate is ready?
Yes, sir.
Right. A 58 years old man is referred to the urology clinic of yours with non-visible hematuria. Can you briefly tell how will you evaluate this patient?
So 58 years old male
Yes.
presenting with
Non-visible
non-visible hematuria. So my main worry is excluding the urological malignancies here. So
Okay.
I will
How many of them will have urological malignancy if you take non-visible hematuриas, if you investigate them all?
Around 9.4% of them might have urological malignancies. So history I will assess clinically with the history and examination. Are there any risk factors for the malignancy? Or are there any different other factors might be causing stone disease or other benign causes to exclude that? And also in the examination, I will do the urological abdominal examination and also the genital examination, digital rectal examination as well to exclude prostatic cancer as well. So after that, anyhow, the patient is 58 years old. My initial management will be ultrasound QUB with PVR and
ultrasound scan shows a mass in the left kidney. How will you proceed?
So in that case, since their main worry is towards the upper tract malignancy, so in that case, I want to go for a CT. So after assessing the renal function, CT Euro angiogram to assess the renal mass and its metastasis, chest and the pelvis also.
Okay. Balagobi, can you show the CT? Next slide, if you just. Gobi, next slide. All right. So the film.
Yeah.
So it is unfair to ask you just showing one film, but what can you see from this?
It's a CT urogram and also the angiogram also there. So in that I can see the left side kidney is enlarged compared to the right side, but enhancement wise slightly less enhanced, and there is a cystic and mixed lesions in the upper pole, left side upper pole, with very fat reaction, and also there is a mass extending from the vein into the IVC, the infrahepatic part of the IVC. So most probably it could be a left side renal cell carcinoma extending into the IVC thrombus.
Okay. What will be the stage roughly, the T stage?
This will be, I'm not sure about the, I want to have the further films to assess the surrounding involvement. But here, if the surrounding involvement is not there, then it should be T3. It might be extending into the IVC. So it will be T3B.
Okay. So you are right, because it is the infrahepatic part. Is there a possibility that it can become T3C once your treatment is completed? Is there any possibility? When will you say that there is contrast enhancement in a renal mass? What is the difference of the HU value you would like to have?
15 Hounsfield difference is there. Then we can consider it as a contrast enhancement.
Okay. So now looking back at the patient, now this is a patient who is having a renal mass going to the IVC, would you like to look for any particular special clinical features on examination?
I want to see whether the patient is having deep vein thrombosis, and also I want to assess the, since I can see the IVC thrombus up to the infrahepatic region here, I want to assess the further extension of the IVC thrombus. So better to have the CT chest as well as, if possible, 2D echo also we can ask to assess the intracardiac thrombus.
Good, right. So all those investigations show that it is in the intrahepatic part only, the thrombus, and the mass does not infiltrate the muscles or the perirenal fat. And so what are you going to do now?
So, there it's a localized tumor extending into the IVC. So other than that, no metastasis. If the patient is fit enough, then after discussing with the patient and multidisciplinary discussion with the vascular surgeon help, I can go for a radical left side nephrectomy with IVC thrombectomy.
Right. How will you take consent for the procedure? What will you tell the patient? What are the main features that you have to tell to the patient during taking consent?
So it's a high risk surgery, and it might carry high mortality and high mobility, but I am not sure about the proper percentage for that. And here we might have to get the control. It might be open intra-abdominal surgery, but we might need to open the chest as well. So consent should be taken for the thoracotomy as well.
What is the incision that you will put if you are doing open surgery?
So here, of course, I have to get a control of the IVC thrombus. So because of that, and also to get rid of the left side kidney. So I want to have a bilateral subcostal or modified bench incision to mobilize the liver as well as the mobilizing the left side kidney.
Yes, once you go in, what are the main steps? Sort of important things that you would do in other than in a radical nephrectomy.
First, I will assess the metastasis. Are there any metastasis other than the which was not visible in the CT? Then I will assess whether the tumor is resectable or not, whether the stage is consistent with the previous radiology staging. Then whether we can, first I will dissect the mobilize the liver, whether I can get above the thrombus, whether it is possible to get the control infradiaphragmatically or supradiaphragmatically. Then I will proceed with the surgery.
Will you be interested in identifying the right side renal vessels in this patient?
Yeah, why I want to see whether, because in this surgery I have to clamp the IVC. While clamping the IVC proximally and distally, I have to clamp the right renal vein also to prevent the thrombus to get into that right renal vein, where only that kidney is going to remain.
Okay, so you have done the surgery successfully and patient has recovered. The specimen had been sent to the pathologist. Gobi, can you show the next slide?
Yes. Yeah.
Yeah, that's the slide of the specimen of this renal mass. What can you say?
Yeah, this shows renal cells with most probably clear cytoplasm. So most probably the clear cell carcinoma, clear cell renal cell carcinoma.
Why those areas are clear?
They are having a glycogen content will be more. Because of that, this will be washed with the staining process. Because of that, cells are clear.
Right. Can you guess the eye subgrade?
No, I'm not sure.
Okay. So now you explain to the patient that you have removed the tumor completely and patient has recovered well. The patient's son wants to know whether this could be familial and that the children of the patient can get this tumor or the cancer. What will you say?
Yeah, there are risk factors, but for the familial risk factors for the renal cell carcinoma, like so, but in this age, 58 years old patient having the malignancy is less likely to go for features. There will be if it's a familial one, then it will be bilateral or multifocal lesions. So compared to that, it's elderly young patient. Here, elderly patient having the renal cell carcinoma less likely to be the familial. So other risk factors might be excluded. Hypertension and smoking, those factors should be excluded.
Right. So what is the rough, any cutoff value of the age of the patient that where you will think of familial malignancies?
The age is, I'm quite not sure, but age is less than 40 years, then we can consider it as a familial.
Okay. So patient has recovered well and tumor has been removed completely. How will you follow up this patient? What will be your follow-up protocol?
Follow-up will be following the surgery. I will have my MDT with the histology. After pathological staging, I will have a multidisciplinary discussion. And this patient, since he had in IVC thrombus as well, we might have to go for a adjuvant chemotherapy in this patient. So,
is there evidence for that? Is there evidence to support adjuvant therapy in this type of patient where there are which is non-metastatic RCC clear cell?
EAU guidelines, I think, suggest, but I don't have the proper evidence.
Okay, okay. So oncologists say it may not be necessary to give adjuvant therapy, but the pathology report says it is PTC. Is it possible? Or have they made a mistake? So how will you follow up this patient? Now it's all sorted out. There is no place for adjuvant therapy, the oncologist says. And so what is the sort of
follow-up will be, I have to, these patients are more prone to get metastasis in future, more than 30% chance to have metastasis. So I had to follow them for to assess the local recurrence as well as to assess the metastasis. So for that, and as well as we have removed the single kidney. So other kidney also, only one kidney is there. So elderly patient more prone to get renal failure. So I will assess the renal function as well as I will assess the local recurrence and the metastasis with CT. Most probably after 3 months, I will assess the patient with a CT, abdomen, pelvis, and chest.
Okay.
Time's up, sir.
So very good, Nishantan. You have done well. That's, I think you almost all the answers, 7 or 8, very clear pass. There's no problem. Few things, if I just want to say for the sake of completion, it's T3B, but it can be T3C if the thrombus is involved in the IVC. Direct invasion is there histologically, microscopically, then it becomes T3C. Because that is a very important prognostic factor when it comes to IVC thrombi. I think the rest, everything is okay. Malignancies, you said 9%, yeah, it varies from study to study. It could be 5%.
Yeah, Nabil sir want to talk, sir. Yeah.
Yes. Yes, sir.
Just I think just butting in. I think at the beginning you must have told that this is not a CT.
Yeah.
The depicted pictures are MRI.
Yeah.
Because you can't see the bones there. Bones are missing. So that is a very basic and preliminary thing you should have told. These are MRI and with or without gadolinium. And then you proceed to describe this thing. But that's a very basic mistake. Okay. And rest, I think I have no complaints. But I think the figures and things like that, I think you got blocked a little bit. I think it should be there, in fingertips, how, what are the possibilities of, having familial tendency to get it, or is it a sporadic one? What are the genes involved? Just display your knowledge. Go ahead with Anuruddha. I just want to correct a very basic one.
Okay, thank you, sir. I think that's all. If anyone else wants to tell anything, I of course don't have much to tell because he answered all the questions. Additional features I asked in the examination, varicocele may be there, ascites, ankle edema. When you have IVC involvement, you tend to look for those things. So we could tell those things as well. I think most of the things.
So what is the age limit you wanted?
Yeah, there is no hard and fast rule. I think 35, you generally, if you operate on a patient who is less than 35 years, you may send the specimen for genetic studies, or you wait for the histology, but then you can look for genetic studies. That's a general thing, but there is no hard and fast rule actually. Anything else, Balagobi?
And again, the mortality figures, I think better to have it in fingertips because there are only 3 or 4 malignancies. So all these major surgeries just have the complication figures and mortality figures, like in prostate, how many people will become incontinent, how many people will be sort of having retrograde ejaculation. The same way, the chance of death, you have to tell, including that, and the complications of hemorrhage and blood requirements and things like that. Better to have put a figure into that.
Yeah, when you're taking consent, I think. Yeah.
And the consent just mentioned the HTU or ICU and the blood transfusion, and this open surgery, and there may be risk of pulmonary embolism and those things also.
Yeah. Basically, when the question is asked about taking consent, you must know the complications with the percentages, common ones. But I think it's okay, no?
Yes,
Shall we go to the next one then?
Yeah.
So next up, Dr. Balagopi will be the examiner, and Dr. Taha will be the candidate. Over to you, Dr. Balagopi.
Can you see my slides? Or?
Yeah.
Okay. So Taha, this patient, 60-year-old retired accountant, is presented with repeated episode of painless visible hematuria for 3 months duration, and there was he also complaining just a dull aching pain in the right loin. He's ASA2 with well-controlled diabetic and hypertension. How are you going to investigate this patient?
So 3 months history of visible hematuria with a past history of diabetic and hypertension. I will start investigation with focused urological history examination and investigation. So history will be targeting risk factors, possible complication of renal or upper tract urothelial cancer, such as smoking. He is having hypertension, past history of smoking, occupational exposure, any past history of chemotherapy, and then any complication because of the tumor, local as well as metastatic complication to brain, lung, or bone. And then in examination, I will look for possible local complication because he might bleed a bit, anemia, blood pressure measurement, and still metastatic and paraneoplastic.
Nothing significant in the examination. How will you investigate?
So I will start with basic bloods with full blood count to look for hemoglobin, and then basic renal function test with including creatinine and electrolyte, and then urine full report to look for to confirm there is our red blood cells. And after that, I will do ultrasound scan, which will tell me whether it is a renal mass or else it's arising from the upper tract, and then which will guide me to perform further imaging such as contrast enhanced CT, CT abdo-pelvis with CT urogram.
Okay, so these are the findings. UFR showed red cells of 60 to 100. Hemoglobin was normal. Serum creatinine 1.6. An ultrasound scan revealed right side moderate hydronephrosis. There was no hydroureter, but there were thickening in the pelvic junction. So what do you think about?
So my suspicion would be he's having upper tract urothelial carcinoma at the right pelvic junction, and because of that he's having hydronephrosis and creatinine is slightly higher. So I would confirm my diagnosis with further imaging, that is CT urogram with CT abdo-pelvis also, after considering nephrologist opinion, because his creatinine is high, and ruling out he is not allergic to contrast medium.
So what do you think the nephrologist will advise regarding
So he will tell, I think, hydrate the patient because it is slightly high. So 100 milliliter per hour for 12 hours prior to the procedure and 12 hours post procedure.
Okay. So now you are waiting to do the imaging after 2 weeks. Now you are repeating the serum creatinine before the imaging. Now is 1.8. So what is going on your mind?
Maybe it may be due to dehydration, or the obstruction is getting worse with the malignancy.
Okay. So ultimately the CT scan was done. Can you elaborate on what do you see here?
This is the coronal plan of CT image, where I can see excretory phase in which the right kidney collective pelvic system is dilated. But even said that, the lower ureter opacity is also there. On the left side, excretion is normal.
Okay.
And the bladder looks normal.
Right. So these are the further images. Of course, they're not all the images. This image was taken at the level of PUJ.
That is an axial plan of CT image. Again, excretory phase, where I can see a thickening of the pelvic junction with a mild amount of contrast in the upper ureter.
Right.
Nevertheless, I want to see the other images also.
Okay, so this was a CT report. They said all looks good. There was a soft tissue thickening at the pelvic junction, which was extending into the renal pelvis. Now, what are you going to do now? What is your plan?
So this should be staged. So I want to see whether the metastatic staging should be done.
Yeah,
so
no metastasis.
So then after that, I will discuss this case in local MDT, specialist MDT with the images, and oncologists as well as pathologists. There are studies, or there are two schools of thought whether to do biopsy before upper tract urothelial cancer. The studies which has shown, most of the time it has been done without biopsy, and more than 90% of the time it has shown that the end cells what.
So what you will do?
In my practice, I would not go for a biopsy, because the CT film patient has typical history, as well as CT images showed there is thickening of the.
Now, patient says sometimes he have a night fever.
So in which case there is a suspicion of granulomatous or chronic inflammation such as TB, which is more common in this part of the world. So I might do basic investigation to rule out whether there is TB, but picture
all the urine tests and ESR normal.
It can, otherwise it can be due to paraneoplastic syndromes
so in this situation, what you are going to do next?
So again, it should be an MDT discussion, and if the patient is considered about the diagnosis, then I would go for a ureteroscopy, retrograde
so
study.
MDT deciding for a ureteroscopy and proceed. And these are the pictures of ureteroscopy around the PUJ and the renal pelvis. So what do you think?
So I can see papillary lesions with irregular areas in the PUJ area. With the third pitch, I can see the calyces also. Probably upper tract urothelial cancer.
So will you take biopsy?
Yes, I will, because I have gone in, so I don't want to miss a
so if you take multiple biopsy, will you do a stenting after it or no stenting?
So there are studies has shown stenting might increase bladder recurrence. So if the patient is asymptomatic, I would not go for stenting if there's no bleeding.
Creatinine is 1.8.
Again, I mean, the tumor is almost obstructing, so I want stenting at the time.
Right. So biopsy, multiple biopsies taken, and so this is a histology report.
So the histology says morphology is compatible with high-grade papillary urothelial carcinoma. Invasion, actually, obviously, it cannot be demonstrated. So it's a high-risk tumor when we consider upper tract urothelial cancer, as it is high-grade.
So what are you going to do now?
So ideally speaking, this patient is having high-risk tumor at the PUJ. So after, again, it should come out with the MDT decision. Probably he will need a right side radical nephroureterectomy with the removal of kidney ureter and the bladder cuff.
Open or laparoscopic?
Again, it's depend on the patient and the facilities available. Studies has shown there is no oncological or functional difference. But having said that, minimally excess surgery will have a shorter hospital stay and early return to work, as well as minimal blood loss.
If suppose, so this is you said is a high risk. I agree with you. Yeah. And now you said you are going for a surgery. Now, how are you going to manage the lower ureteric orifice and the bladder cuff?
It can be intravesical, extravesical, or endoscopic manner. So extravesical is we can go up to the bladder ureteric insertion and we can take the thing off. Otherwise, we can do a vesicostomy and do the surgery. Or else we can do rip and pluck method, that is endoscopically, we can dissect around the ureteric orifice, and dissection will be completed from the superior level.
Suppose if you are doing during a cystoscopy and dividing the ureteric orifice, how will you confirm when you pull up that you have removed the correct ureteric orifice rather than just cut off of the ureter?
Then again, I can do on table. If we have facilities for on table flexible cystoscopy, I can use that. Or
what about visual inspection of the distal end, just to see the flower kind of appearance of ureteric orifice?
Yes.
Yeah. Okay. So this is the specimen. So radical nephroureterectomy done. And do you think it's a good specimen, or? Tumor was around the pelvic junction and the renal pelvis.
Yeah, I mean, around the pelvic junction, there is extra pelvic tissue is there. So I don't think there's be tumor spillage or tumor spread at the time of operation.
The histology comes as fat also infiltrated. What is the staging, you think?
That is a T3 stage.
Right. Will you do a lymph node dissection with this surgery?
Again, in high risk, that is more than P2, there is indication for lymph node dissection in upper tract transitional cell cancer, otherwise not needed there.
What is the concern regarding the bladder in the future?
So future, I mean, after radical nephrectomy, there is metachronous lesions like 20 to 47%. So bladder should be under surveillance. and study around like OMDTC or one installation of post-op mitomycin will reduce the recurrence, the bladder recurrence, like 40%.
Right. Why we have less evidence in urothelial cancers, upper tract urothelial cancer? We don't have much evidence. Why is that? Because there's a less research, and I think time is up, Trina. Yeah, thank you, Trina. Time is up. So, yeah, those are the questions I want to ask. Just tell that Tim O'Brien research that told about post-op MMC after the upper tract. Yeah, Taha did very well, and you have covered almost all the questions. And Neville sir and Anuruddha sir.
Yeah. Yeah, I think when you have doubts about upper tract tumors, somebody might ask, what is the place of urine cytology, combination of urine cytology with the imaging. So, and at the beginning, you were arguing against ureteroscopic biopsy, but I think you have to be a little more confidently say that, if these radiological features are doubtful, I'll definitely, you are going to do a radical surgery. Suddenly, if you find it's a malakoplakia or some sort of chronic inflammation or TB or something like that, I think you will regret. So because of that radicality of the surgery, be more confident in saying that I would like to get histological or macroscopic and microscopic diagnosis before I proceed with radical surgery. So I think you should not hesitate. I mean, always try not to sort of depend on the MDT. Now, this country, the MDT, you will be the only urologist sitting there. Maybe your colleague is operating in the listing. So you are the MDT surgeon. So MDT is there to take, if there is any controversy about radiotherapy or, histology, pathology, there's a controversy, then of course MDT you can discuss. But it's good to say that it's at the MDT, but you must tell your view about it. So you say that, putting a foot down, that this lesion is not, if it is a sort of a pelvis full of tumor, then of course there is no doubt about it. But when it comes to U-junction tumor, you say that I would be comfortable with doing a rigid ureteroscopy, though it will involve another anesthesia. Say that you are aware of it, and we're taking either brush biopsy or a punch biopsy, combined with urine cytology. I will be fairly certain before I go in for medical surgery. So that's sort of show that you are going for histology. Okay, and again you said something about the lower ureter disturbs me a little bit. Psychostomy. I mean, this can be 40% chance that maybe a malignant urothelium in the bladder as well with field changes, because when you have got an upper tract tumor. So disturbing it by any means, opening it up. What do you mean by psychostomy? To get the, did you say that or?
Yes, I mean that.
Laparoscopic open excision with a bladder cuff. Bladder cuff means half of the bladder. You must remember that. Because bladder cuff just means there's a small cuff because ureter opens into the trigone. So taking half of the trigone means half of the bladder is gone. So it's not an easy thing. Other thing is a Semper's technique. But we have been describing Semper's method. Semper, you dissect up to the deep trigone and push it in. So often asked question is that, what about the tumor spillage and things like that? But there's no evidence to show that there is tumor spillage occurs in technique if the lower urethra is held. And that also you will decide in your preliminary ureteroscopy. There are no changes, in situ changes, or anything in the lower ureter before you decide on Semper's ureterectomy in the lower, right? But don't open a malignant bladder for any reason.
Okay, sir.
Thank you, sir. Anuruddha sir.
Bobby.
Yeah. Okay.
Monipriya, I want to ask one question. Your first question is, how will you investigate this patient?
Yeah, because Anuruddha sir was asked about assessment of hematuria in the first question. I don't want to straight away go for an investigation, but Taha was telling everything. Yeah, better to just see what is the question they're asking. Yeah, I ask how will you investigate, just to sort out the time. Yeah. So, Arunda sir, do you want to give any input, sir?
No, I think Neville sir said everything.
Serena, you can move to the next one.
Stenting.
Yeah.
What about stenting, sir?
Neville sir, regarding stenting.
Stenting increasing the blood recurrence is not an evidence-based. I don't know whether there are any good series to show that. As you said, that there are research is minimal in the subtract tumors. So, but a stenting in this renal failure chap will be essential in this case, because this may be the only functioning kidney, because it's a larger than the other one when you look at it. So at least until we do the nephrectomy, it's always better to have the stent, so that his renal function will be stable by the time you go to site. That should have been the answer. You will go for.
Can we argue that the stenting might make the surgery also a bit difficult, because sometimes when we have seen these sort of upper tract tumors, you're supposed to take the ureter as well as the sort of part of the periureter tissues.
Periureteritis will take about 6 weeks to happen. So I think our rule is that within 30 days, if possible, to go ahead with surgery. So leaving it for a short period will not lead to serious ureteritis or dissection problems. So I would, in a renal failure person, I would definitely read, because you never know. I mean, if there's a lot of edema after the biopsy and things like that, this system might get infected, and then there can be problems, which will postpone the size. So I think by all means, if there's a PUJ mass, leaving a stent is more beneficial than not.
Thank you, sir. Yeah. So that's.
Can I ask a question?
Yeah, Serena, yeah.
Just now, if Dr. Balagopi was asking prior to the CT, now prior to the CT, if we stent, will the filling defects be seen adequately because the stent will drain the contrast through the ureter? Will there be effect like that? If there's a large enhancing lesion, of course, we'll see, but if the small filling defects can be missing due to the stent.
Possible, Selena. But this, of course, is a very large papillary thickening all around the PUJ and the renal pelvis. So yeah, possible.
Yeah, closer look at through the PAC system will always show the stent separately. So a good radiologist can always differentiate that from the mass which is surrounding the stent. So stent will not mask the mass effect of the lump. So that's not a problem.
Thank you, sir. Tirina, shall we move to the next one?
Yeah, so the next case is by Anuruddha sir, and Dr. Munipriya will be the candidate.
Yeah. Okay, we'll start. A 42-year-old man with non-specific abdominal pain has a mass in the left kidney in his ultrasound scan. It is solid and measures 2.5 centimeters in diameter. Patient has well-controlled hypertension, has no other comorbidities. In the history, there is nothing significant. Examination also couldn't find anything positive. What will you do now? He has a mass in the ultrasound scan.
So anyway, I will start from the history and examination, a brief history, especially regarding the risk factors and the family history and previous surgical and any surgical intervention to the same kidney. And then examination wise, I want to do the abdominal examination and whether the kidney is palatable, and then any other abnormalities I can feel. So according to the ultrasound scan, there is a lesion in the kidney. So I would want to know about the size of the lesion and the ultrasonic appearance of the lesions, whether it is a
it's a solid mass, 2.5 centimeters in diameter, left upper pole.
Right. And so it is a small renal mass. So in a small renal mass, all the small renal mass is not a malignant tumors. So 20%, 20 to 25% are benign tumors. So according to the studies, there is a place for ultrasound guided biopsy or the CT guided biopsy for small renal mass. So anyway, we have only having ultrasound images. So I would do contrast enhanced CT urogram with the angiographic phase to get more information about the renal mass.
Okay. So we have done a CT. You do only the urogram or anything more? Angiogram plus?
CT urogram with angiographic phase. Because it is a small renal mass, I want to know the vascular anatomy of the kidney.
Can you show the CT?
Can you see the?
Yes.
Not, yeah.
Right. According to the appearance of the CT, the right side kidney seems to be normal, and left side there is a upper polar heterogeneous enhanced thin well circumference lesion is there, and so most probably it is a radiologically diagnosed, we can tell as a renal cell carcinoma. Further details, I want to go for the either console view of the CT and other films to find out whether extension and the renal vein invasion and those things.
Can it be a benign lesion?
The appearance seems to be heterogeneous because of that. The benign lesion is less likely, but anyway, the small renal mass at about 20% is benign.
Maybe Anurtha sir lost a connection or?
Yeah.
Sir, muted. Sir, you are muted.
Sorry. I'm sorry. My question was, what is the commonest benign neoplasm in small renal masses?
So, angiomyolipoma.
Okay. So at the MDT, radiologists are confident that this is a RCC after looking at the console. He has only well-controlled hypertension, only no other comorbidities. What are your plans? Chest is clear, CT chest is clear. There is no evidence of mets.
So I would happy to go ahead with the partial nephrectomy for this patient, and patient is, because it's a well circumference upper polar lesion, the nephrometric score.
Patient want to know whether there are any other options.
This patient is young. The best option would be the partial nephrectomy compared to other option. But anyway, I would discuss with the patient other available options like the microwave ablation or the radio frequency ablation and the cryoablations. So out of these three, the microwave ablation showed much more benefit. But when we come to the age of the patient, the best option, because there is no other comorbidities, we can go for the 100% tumor free, the surgical clearance, oncological clearance by doing the partial nephrectomy. So I would discuss.
Who are the people where you will prefer to give focal therapy?
If it is the multiple bilateral tumors and single solitary kidney with the malignant lesions, and the comorbidities, the very high risk for surgery, and the very elderly patients, we can go for the minimally invasive therapies like a microwave or the radiofrequency ablation.
Wife wants to know whether we are certain of the diagnosis of cancer before surgery.
In that case, we can go for the biopsy. That is ultrasound guided or the CT guided biopsy. There was an initial thought the seeding effect, but nowadays the evidence says there is no seeding effect by doing the biopsy for renal cell malignancies, especially because of the type of needle we use for biopsy.
How will you get consent for the biopsy, renal mass biopsy, if you decide to go ahead with the biopsy?
In that case, I have to take the consent for the risk of bleeding and the bleeding risk, and the sometimes histologic may be not conclusive because of this is a small renal mass. Sometimes the sample may be inadequate, or that possibility is there. So because of that, I want to take special I want to explain the negative effect of biopsy as well.
Can you tell about the percentages of those problems that you mentioned? You have any idea roughly? How many of them will get sort of a hematoma and significant bleeding like?
Hematoma and the significant bleeding, it is less than 5% patient will get this complication, and the missing the biopsy may be inconclusive about again 5 to 10% of people.
Right. So you said about 20% of them will be benign.
Yes.
What will be the sort of non-diagnostic rate of biopsies that you said as a disadvantage? How many of when you do the biopsies? Roughly about
5 to 10%. Sir.
Okay. Can you tell, you said you will go ahead with a partial nephrectomy, and after explaining all these things, the patient and wife are ready to go ahead with the partial nephrectomy. Can you tell how you will take consent for that partial nephrectomy?
In partial nephrectomy,
what are the main things that you
do? Main thing is first thing is I want to discuss according to the available facilities, the mode of surgery, that is open versus laparoscopic partial nephrectomy, and if it is a laparoscopic partial nephrectomy, I want to discuss the conversion to the open as well. And then
what are the advantages of laparoscopic or open for partial nephrectomy?
Advantages wise, the open versus laparoscopic, there is no oncological advantages rather than the pain and the hospital stay may be reduced.
Okay. So what are the other things that you will tell about the consent?
In consent, then I want to say about the margins. Sometimes the histologically margins may be involved. Maybe histology comes as margin involved, but separately we would send the deep surface base of the tumor biopsy, as well as we will cauterize the surface. Because of that, even single cell layer is adequate for margin clearance. Other thing is in some anyway, I want to get the consent for radical nephrectomy as well. In some cases, even we can see the exopitic or the upper pole lesions, the vascular supply and other things may be change during the operation, our decision might be changed.
Time's up.
What are the other complications that you anticipate after partial?
That is pseudoaneurysms can get pseudoaneurysms after while healing the surgical site, and if we open into the calyx, urinary leakage or the urinoma can take. Yes.
Okay. Thank you. Time is up. I of course will give pass mark, but you're a little too slow. You would have answered many more questions if you answered little faster, Monipriya. Otherwise, I think you are okay. Some of the percentages, there were subtle differences, but I don't think they are that serious. I think as Neville says, when you tell about this taking consent, you have to be a little more confident and give some percentages so that the patients and the family will know better. And Neville, any comments?
Yeah. Regarding biopsy, I think the relatives motivating you to do the biopsy doesn't sound good. So the relative comes and say that I would like to get histology, then you decide to do a biopsy, is something, should not happen. So you should have made up your mind before the relative comes and say that the biopsy is necessary. So if you think that biopsy is necessary, you must say so. So if it is a larger tumor, say closer to 4 centimeters, and if the radiologists are pretty confident that this is a renal cell cancer in their radiological findings, okay. So what you might have to say that is that even if it is positive, I am going to take this tumor out. If it is negative, still I am going to take this tumor out. So the biopsies will just increase the chance of complications. If it is 2 centimeter or small biopsy, which when you have a doubt, not the relative, you have a doubt, then you will go for a biopsy because 20 to 30% will come as an oncocytoma or angiomyolipoma. But angiomyolipoma, again, these the black areas, we have commented on that, the dark areas, it's rather than inhomogeneous appearance, those may be fat-filled angiomyolipoma. So you never know. So if you could have mentioned about the dark area, saying that it's a possibility of angiomyolipoma, but then still, if it is close to 4, I will go ahead with surgery because there is a possibility of leiomyosarcoma. So, you have to be confident. You have to make up your mind about doing the biopsy or not before somebody asks you. So you say that. If it's a small tumor, yes, you say that we have already decided to go ahead with a CT guided biopsy. Because if it comes as benign, I'm going to adopt a watchful waiting policy. So you tell your reason as well, straight away, right? And again, minimal invasive therapy, Anuruddha asked about, say, this cryotherapy and microwave, and RFA is the most commonly done one in our setup, radio frequency ablation. So that you have to know the UA guidelines about it. Some of these things are still at experimental level, so they are not strongly advised. So, but if they are advised, you say that the UA, according to UA guidelines of 2020 or 2021, these will be offered to small tumors. So always quote some guidelines. So that will show you that, so that you are more confident. Okay. So I think those are the comments I would like to make. So I think otherwise I think you will probably pass, but I think you would have done better. Coming closer to 6 or 7, sorry, 7 or 8. 7 or 8.
Okay, sir. Thank you, sir.
Trina,
we can move to the next one, Trina.
Yes. So next one is again by Dr. Balagopi, and Dr. Suranga will be the candidate.
Yeah. So 63-year-old farmer presented with the episodic hematuria for 2 months duration. And at the general surgeon have seen the patient and already have done the ultrasound scan, and he's referring to you. And what do you see in this scan?
This is a 60-year-old patient and presented with the episodic hematuria, and ultrasound has done. I can see the ultrasound. There's a bladder with a big mass. I can't say the exact site because of the site can't see. And there's the big mass probably in the posterior wall.
Is it the left side posterior wall or right side posterior wall?
I think
okay, so this is a report. There's an 8 centimeter solid growth at the the left base and lateral wall with left side moderate hydronephrosis and hydroureter. So what is going on in your mind?
So it is an 8 centimeter solid mass. So according to the solid mass, so it's probably some muscle invasive, and there's hydronephrosis and hydroureter. So that means a very advanced. That's my worry, and then I need to go for a further assessment of this patient.
So what are you going to do next?
So I will go for the staging scan like CT, abdomen and chest, abdomen and chest and pelvis with a urographic pace and the flexible cystoscopy to visualize the bladder. And
so
then,
what is the advantage of doing a flexible cystoscopy? Why we can't go straight away for a TURBT?
Yes, the flexible cystoscopy is it's not involved in the general anesthesia, and or can do under local anesthesia. So you can see categorize the lesion, whether it is a solid or papillary, even though it is in the ultrasound. And then is there any other the possible lesion, like is there any recurrence or any carcinoma in situ in the rest of the bladder? So before you plan the definitive management, then we can have an idea and then go for a cystoscopy.
Right. So you said you will do a CT scan.
Yes.
And so this patient underwent a TURBT under general anesthesia. So the histology came as high grade, at least high grade T1. They couldn't see much detritus or muscle to comment about this. So what are you going to do now?
So it's according to the NICE guideline, it belongs to the high risk category. It is high grade and high grade and PT1 disease.
So
and,
do you agree with this histology?
No, it is at least one. So I have to confirm with after 6 weeks, need to have a re-TURBT that will upgrade the staging by 30% as well as the residual disease by 25 to 50%. So actually need a restaging TURBT in 6 weeks time, and until then I will stay with that diagnosis.
Right.
And
so you do a re-TURBT in 6 weeks time. Now the histology comes as you have taken a very deep TURBT, and now they are saying it's a high grade entering into the muscle as well, high grade T2. Yeah. Do you think new methods of tumor visualization made any difference in this patient from the first TURBT?
There are few trials, actual photo trial. They said whether the blue lights will different the management plan and the narrow band imaging, and but in this case actually it is a muscle invasive. there won't be a big difference.
Okay, so
actually, it's for
yeah,
a
so in this
superficial
patient, do you think it won't make any difference? Right.
No.
Right. So you have done a preoperative CT, and that's showing there was a very vesical fat changes, but no gross infiltration. Multiple pelvic lymph nodes, mainly the internal iliac and external iliac, and they are 6 millimeter to 8 millimeter in a size. So do you think these lymph nodes are clinically significant?
In pelvis, the 8 millimeter lymph node is clinically significant. In abdomen, actually, it's 1 centimeter, 10 millimeter. But even with small lymph node, the micrometastasis can be there. So imaging, we can't give 100% answer, but ideally it should be histological.
So what may be the reason for this perivesical fat change? It's a preoperative CT.
If it is a preoperative, it may be the extension of the malignancy as well as the some inflammatory changes due to the cancer.
Okay. So histology is reviewed, and so READ-TURBT done, CT was discussed in MDT. You are coming to a conclusion. This is a high-grade PT2. They say it's just like a reactive lymph node because they say fat high level is preserved and is mentioned as N node, M node. So how are you going to proceed?
So actually, with the MDT decision, I have to with the MDT decision, I have to see the patient again, and with the cancer nurse specialist, and then I will discuss the options of treatment with the patient. And there are a few options, and one thing is the radical cystectomy with lymph node dissection and the urinary diversion, and with the with the neoadjuvant chemotherapy as well, that has a survival benefit according to advanced bladder cancer trial. And
so you prefer radical radiotherapy or surgery in this 63-year-old man who's also had a moderate height and nephrosis and hyperureter? Which treatment option you prefer?
Because he's a 63 is relatively young patient, and when I assess him, I will go for the performance status as well, like a colonoscopy performance status, and this see the fitness for the big surgery, and then I prefer for radical surgery if he is fit for the cystectomy and the urinary diversion, because of having hydronephrosis as well as the high-grade PT2 disease.
So you mentioned you are going to give a neoadjuvant chemotherapy. What is the scientific evidence?
Because in neoadjuvant chemotherapy, if you according to the there is a trial has done, advanced bladder cancer trial, and there's a 5% absolute improvement if you give neoadjuvant chemotherapy, and there's
okay. Suppose you are going to give a neoadjuvant. As a surgeon point of view, what is the problem?
The surgeon point of view, so that will delay the procedure, as well as if you give neoadjuvant chemotherapy, that will sometimes the patient's condition may be deteriorated, the performance status will be low.
So if you diagnose the bladder tumor, if you diagnose a bladder tumor, within how many months you have to operate according to the NICE guidelines?
I think it should, according to the NICE guidelines, it should be within 12 weeks. We have to complete the treatment option actually, but in the UK there's a 61 days, and yes.
So suppose if you are planning for a neoadjuvant, what is the blood investigation you have to be carefully look into?
So WBC count, we have to see the neutrophil, and as well as the calcium and the platelet. So we have to see preoperatively before put in neo unit.
What about EGFR?
Just yes, sorry, EGFR as well as the serum creatinine.
Suppose if you are doing a ideal conduit with radical cystectomy, what kind of anastomosis you will do? What are the types of anastomosis you know?
Yes, there are two types of anastomosis, villus anastomosis and Bricker's. Both have an advantage as well as a disadvantage. And if you do a villus...
Suppose if the EGFR is 30, will you do a neobladder in this patient?
So EGFR 30 is one of the contraindication for neobladder.
Right, thank you. Thank you. Time's up. Time's up.
Okay.
Yeah, again, he was up to the mark and he did very well. And Neville sir and Another sir.
Bobby, I think if you can just rush through your questions and your answers expected, how do they tally with the answers given by Surangan? Were there any shortcomings? Do you have the answer script with you? Or?
Yeah, so I have it. So anyway, sir, I'm going to share with them. So they will see it.
Okay.
Yeah.
Well, I think I also feel that he has done well, but when it comes to preoperative flexible cystoscopy, when there's an obvious cross bladder mass, what advantages and what indications are there for flexible cystoscopy? Are we routinely doing? So you have to give your opinion straight away, saying that if the patient shows, the young patient relatively, and shows signs of or the history of urethral obstruction, like a stricture or maybe a BPH, early BPH, only indication I can think of is anticipating urethral obstruction, outlet obstruction, because once you go for a QRBT, suddenly you find a missed stricture, that will be a big problem. So other than that, I don't know whether there is going to be any other advantage, because we are going to achieve same thing when you are doing the rigid cystoscopy, because you are going to take the random bladder biopsies if necessary, you are going to do a deep resection. So all the advantages of flexible cystoscopy is there. So preliminary cystoscopy, if you have mentioned it, and if you want to argue back and sort of safeguard yourself, you must say that only I don't know whether others will agree, but I will perform this type of obvious in the CT and ultrasound. So obvious large tumor mass, which is we are nearly 100% sure. I think we'll be straight away going ahead with rigid cystoscopy and resection. When there is any place for flexible cystoscopy. So as a mature candidate, I think you should just say that, flexible cystoscopy is diagnostic of undiagnosed, hematuria or investigation of hematuria. There is obvious bladder mass, which I am going to do at URBT. So only if the patient has some unexplained outlet obstruction features, I would consider doing a preliminary flexible cystoscopy to not to have surprises during my TURP. So that is one thing you have to sort of confidently say. And other thing is you said something about histological upgrading in secondary section. You said something about 30 and 50%.
No, it's a residual tumor 30%. Tumor upstage 10%.
Yeah,
it's not 30%.
Yeah, exactly. Yeah. No. So the figures are too high, and upgrading is not that common, because the grading you will anyway get. But our problem is whether the muscle invasion is commented or not. So the upstaging will be there if the muscle is invaded. So that will be there up to this level. So these figures are little high. You mentioned about photo trial. Yeah, so photo trial outcome you have to say, but then you are talking about, you quite correctly said, photo trial is for superficial bladder cancers, not for the muscle invasive bladder cancers. So photo trial you have to mention and discard. And when it comes to radical cystectomy, I think you managed well. Yeah, I think you were sort of wondering whether to do a cystectomy or do a bladder preservation. So I think best is to start by saying that, I will, this is a muscle invasive cancer, and he's a relatively young person, and all the evidence shows that, radical cystectomy gives the best answer. Only for small volume tumors, there is evidence to show that bladder preservation therapy in a selected group. Preservation therapy in the sense of resection, radiotherapy, and chemoradiation will help. So in this particular large tumor, so always refer back to the patient, refer back to your case. So that shows that you are managing this particular patient rather than generalizing. I will refer back. I will just. My opinion is that we should go undergo surgery, and having bilateral hydronephrosis shows that there is deep trigonal invasion as well, and there is a lymphatic permeation in the bladder wall. So all are speaking against radiotherapy, and so I will go. So you give your opinion very strongly when it comes to that particular case, rather than wobbling, saying that radiotherapy also may be okay and give. So you can discuss it in the MDT, but you have to put your foot down and give your opinion about how you are going to manage this particular patient. So be confident on that. And neoadjuvant trials, it's better to mention a couple of trials if possible, like one trial at least, that neoadjuvant therapy, that ABCD trial you mentioned about it. So mention that confidently and say that for large volume tumors, it has shown, I think, and then you have to, at the same time, if you have mentioned about post-operative adjuvant treatment after radical cystectomy, then indications, it will be even better. So I think, but you definitely pass, there's no doubt about it. So again, I think aim at the highest at 7 and 8. Okay?
Thank you, sir.
Okay, thank you, sir.
Tilina, you can move to the next one.
Balagobi, can you
sir.
do the next case? My internet says some problem, Balagobi. It's very poor connection. I don't know why.
Okay. Yeah, okay.
Please go ahead with your one.
Yeah.
So the next candidate is Dr. Hillary. Over to you, Dr. Balagobi.
So hope you can see me, Dr. Hillary. Can you see me the slide?
Yeah, thank you.
Yeah, so right. So this is because there are a few cases I have made not to miss, because these cases will come again in 3-4 places. So I will just cover this one. This is a 30-year-old primee with a POA of 33 weeks, referred from Oxford with severe left side loin pain with nausea and vomiting. What is going on in your mind?
The most important thing is upper tract obstruction, most probably with a stone. And so if that is the case, she is in 3rd trimester, and it could give rise to complications of upper tract obstruction, like urosepsis or obstruction, which could lead to maternal and fetal issues, and even preterm labor, early rupture of membranes, and even fetal loss. So that is a problem. So keeping that in mind, I'll investigate further to make sure that the complications I have are not there. I'll do a full blood count, UFR, urine culture, the serum creatine, and the inflammatory markers.
So what imaging you are going to do?
I will do an ultrasound scan of the abdomen, and I will specifically request for observation of the urinary jet and resistive index to see whether there are supportive evidences for me to, whether the sonographer can appreciate the urinary jet in the bladder in the ipsilateral side. And I will clinically also examine.
Now, how are you going to manage this patient pain?
So there are limitations of use of non-steroid anti-inflammatory agents. So the pain relief wise, we have to resort to paracetamol and Rapidane and Panadine, and the opioid analgesics. And
why you are worried about giving NSAIDs?
In the pregnancy period, when you give non-steroid anti-inflammatory agents, there is a risk of patent ductus arteriosus and the closure and these things can affect the fetus.
So anyway, fetus will have a patent ductus arteriosus.
Yeah,
you are worried about what?
Non-closure of the ductus arteriosus.
So what mediator is reduced when you give NSAIDs? Okay, so the prostaglandin, isn't it? Right. Okay, so you are worried about premature closure of PDA, and can it cause oligohydramnios? Again, reduction of the prostaglandin affect the renal blood flow. It can cause oligohydramnios. Right. Do you think pregnant people have a more risk of developing urolithiasis?
There are some reasons for them to develop more more stones during that, but in the same time, there are some factors that are preventing stone. So overall, when you combine everything, there is no increase preponderance in the pregnancy to develop stone.
Okay, good. So you said you are going to do a ultrasound scan. Now, one thing you said, you will see ureteric jet. Yeah. Now, the physiological hydronephrosis is common in right side or left side?
It is more common. It's more common in the right side. It's the reasons given the cushioning effect of the sigmoid colon on the left side, and the more right-sided sort of deviation of the uterus sitting on the pelvic.
So how will you differentiate whether this is a physiological hydronephrosis or suppose it's a pathological hydronephrosis in case of stone is in the distal ureter? Suppose stone is in the VUJ, vesico-ureteric junction. Patient have a hydronephrosis in hydroureter. How will you differentiate whether this is a physiological hydronephrosis or is the pathological hydronephrosis? One thing, of course, you said ureteric jet is a good thing. But about extent of hydroureter, in physiological hydroureter, up to what point you will have the hydroureter?
In the physiological hydronephrosis, that the hydronephrosis will be up to about pelvic bridge.
Yeah, very good. So here, yeah, so you have to see the distal ureter, the extent of the hydroureter, right? So this is the ultrasound scan. So what do you see?
Okay, I can't actually see.
Can you see now?
No, I'm still in the first sort of like 30-year-old primary POA 33 week. That is what I see.
You can't see this now.
Slides are not progress. It's still in the.
Okay. Can you see now?
Yeah.
Okay. So what do you see in this ultrasound image?
So this looks like pathological hydronephrosis. I can clearly see the calyces are blunted out as well, and the corticomedullary thickness is also diminished. This looks more like pathological obstruction to me. So in this case,
so now this is the sorry. So serum creatinine was high. Can you see now?
Yeah. You can see now.
Okay, serum creatinine was 1.8, and the CRP is 167. Ultrasound says left side moderate hydronephrosis with 1.7 centimeter PUJ stone.
Yeah.
So what are you going to do next?
So now there is significant pathological obstruction of the renal pelvis. I will make sure the patient, I will discuss this with the patient and the gynecologic, so the obstetric team as well. And I think this patient will benefit from decompression of a ureteric stent up until she reaches about 38 weeks. Until then.
So do you think any other option other than the JJ sending?
Then the other option is the percutaneous nephrostomy drainage, which is.
So in this patient, which method you prefer?
I will prefer retrograde stenting, because in my practice it's going to be difficult to organize the percutaneous drainage. I understand that the percutaneous drainage can be done under local, but the pressures are lesser when you put the percutaneous drainage, and you can drain better.
So what are the problems of putting JJ stenting in a POA 33 weeks?
It's going to be technically demanding.
For the urologist point of view.
Yeah, it's going to be technically challenging, because there is a uterus pressing on the bladder as well. And there is a significant anxiety of anesthesia. But in the female,
is it positioning is easy?
Positioning is not. It's a bit challenging, but it's not difficult. Can go ahead with the lithotomy position, so the main reason why I find this retrograde stenting can still be done.
Suppose if you put stent in a pregnant people, what is the main problem with the stent in pregnancy?
It gets encrusted very easily, but having said that, is in POA 33 weeks, she's probably going to deliver in about 5 weeks' time. So probably during the next 5-6 weeks, that encrustation is not going to be a major problem.
So gynecologist and urologist and the patient ultimately decide to do a PCN, and because mother is worried about premature labor and the miscarriage, so they did the PCN. So how are you going to manage? What is the next step? Okay, you put a PCN and patient is improving now.
So since the patient is improving, then I can transfer the care to the obstetric team to manage the pregnancy. And once the delivery is done, then I'll take over, I'll reassess.
Mother is asking, doctor, can you recommend a ESWL that is done for his family member?
Yeah, ESWL is contraindicated in pregnancy. So that is out of the options. So I would suggest management post-delivery. And up until then, she'll have to be on the...
So if a pregnant mother come with the stone, which trimester is a better time for an elective laser lithotripsy?
Second trimester would be the ideal. So we can go ahead and do a safer lithotripsy with laser.
Okay. So do you think keeping this PCN is useful to do the PCNL after the delivery?
Well, that's an option, but I prefer to choose my own track, and I usually gain access to the kidney. So,
so why you prefer your own track rather than a track is already there?
It depends actually. Like if the track is giving me good enough access.
Right. I think time is enough. Yeah. Thank you. Thank you, Dr. Hilary. Thank you.
Thank you.
Neville, sir.
Yeah, I think. Any comments from Gobi, the examiner?
So yeah, he did okay. Yeah. Regarding decision of stenting in the POA 33 weeks, I thought the better option will be something minimally invasive. So I was prompting and I was asking again and again. So just to see whether you are changing your decision. Yeah, Neville, sir.
Yeah, that's a good point. Yes, I think when the examiner is trying to push you into the safer havens and oases, don't resist. So don't ever say that. I mean, they may think that we are from the jungle, you know. That when their facilities are not there, I mean, everybody thinks that the PCN is just available for any hospital. You are coming and getting the FRCS urology. So go according to the guidelines. I think you can give your grievances and problems later on. Okay, but don't start with it. So just say that this is high CRP and this is probably an infected situation where the PCN drainage is definitely much better than just stenting, with all its difficulty of putting a stent with the distorted ureter. Okay, and suppose if the stone is stuck badly and you have to use the URSIL to get rid of the obstruction, suppose there is a stricture, then you have to do a stricturotomy, laser stricturotomy. So all these procedures will be involved in a 33-year-old mother with a high CRP. So high CRP is a dangerous thing. So you will end up in a AKI, because why her serum creatinine is high? Because the other normal looking kidney is also not functioning, because she is definitely has gone into AKI. Because if you have one good kidney, why should her creatinine should go up? So on those grounds, I think the safest and fastest procedure will be a PCN. So and then say that if the radiologist is on leave, there's no radiologist for 100-kilometer radius, then I will think of putting a stent. So very difficult for you to argue and win that. So especially when sympathetic examiner is trying to push you, take this thing and grab and say that, okay, I would like to revise my decision. I will go for PCN and give all the good things about PCN, right? So the reasons are that he's going into AKI and creatinines are high and there's high CRP also. So all these conditions, I don't think you can argue and win about stenting. Okay, so this is kind of a basic management problem. So don't get into this ditch of PCN against this thing. So I mean, later on, you can quite rightly, I mean, when you are putting the stent, there's another problem because you need a longer stents, because the urethra is also meant a lot. So sometimes they use multi-coil things. So, but you can argue, but that is my basic point. That
I think
and then about
I didn't catch the clue given by God.
Yeah, sorry. Yeah. So try your best to sort of take the message. Yeah. Right. And then about the non-invasive investigation of identifying physiological dilatation, that is brachypelvises and other things, you can mention about renal resistive index. I mean, if there's a good radiologist, they can do a RRI, and then that will show, that will give some idea about physiological and differentiating between pathological and physiological obstruction. All the other facts I agree. Other than that, you can mention about RRI. Okay.
And so regarding answer about using PCN as a PCNL, yes, you can argue that you will make a own track or not, but you can say to do a re-imaging after the delivery, you can do a non-contrast CT and see whether this PCN is in a correct calyces or correct pelvis. Then you can take a decision rather than saying, I will make my own track. That's a rigid answer. I thought.
That sounds little. Other thing is that you could have argued by saying that once the pregnant ureter goes down, the lateral PCNL tracks, they all get distorted. So as Balgobi said quite correctly, you have to do a nephrostogram or track imaging study before you go through the same track, because track get totally distorted during pregnancy. So the track may not be straight going into the track. So after that only you must say that, in which case if the track is distorted post pregnancy, then I will make a fresh track into the stroke, right? Okay, so I think Hillary will definitely pass, don't you think so?
Definitely,
but he again could have.
So this scenario, sir, this will come in infection station. It will come in the emergency station. It will come in the stone station also. This scenario definitely you are going to get. Because they are, so it can come one of the stations. So that's why I don't want to miss this scenario. Tilina, if time permits, we can do one more case quickly and we can wind it up. Is it okay?
Yes.
Sir, are you ready, sir? So you are going to do it, or?
It's yours, Balagobi. I think it's useful to do your other case.
Okay, sir.
We'll do it quickly.
Yeah, Tilina, I will do the next one.
You have to pick a candidate.
No candidate.
So
if you
Yeah, I
Don't
can.
pick me.
I'm ready, Gobi, if there's no
okay.
one.
Okay, Taha
We
is
will know
ready, right?
who's Balagobi's best friend now.
Yeah,
I will go for it.
Taha, yeah, Taha, can you see the slide?
Yes, Gobi. Yeah.
Okay. So this is a 68-year-old old man who is from the elders' home, admitted to the medical casualty ward with some confusion and fever, and he's on long-term catheter for urinary incontinence. And they have referred here, referred to you because they are saying he's having a scrotal swelling. So this was the appearance. Can you describe this?
Slides are not moving, Gobi. No?
Okay, so yeah. So I will share again. Can you see this picture now, Taha?
Yeah.
Okay.
Actually, this patient, 68-year-old from an elderly home with long-term catheter. I can see a picture of swollen testis with a blackish area on the posterior aspect and the inferior aspect, with the reddening of the skin. My main worry is whether he is having a necrotizing fasciitis, that is the Fournier's gangrene of the genitals. So I will approach the patient with ALS, adult life support protocol, with the stabilization of the patient, and then I will take a focus history and examination.
Yeah, you can his catheter also, right? So you are concerned about the Fournier's gangrene.
Yes, sir.
So so what is Fournier's gangrene?
Fournier's gangrene is a necrotizing fasciitis of male genital area as well as perineum, where it is a multi-organism infection with multi-organism, mostly anaerobes like anaerobes and bacterioids, Clostridium, as well as gram-negative such as E. coli. The pathogen.
So why there are multiple bacteria causing this? So what is the pathophysiology?
Because source of the infection may be from the urinary tract or else the anal tract. So that is why, or maybe from the skin as well. So that's a reason for multi-organism infection with multi-organism.
So do you think one bacteria help the other bacteria, or?
Yeah, there's synergistic infection, and then.
Yeah. Okay. So so what are the questions you are going to concentrate the history, just to make sure you're not missing anything?
So I will focus on whether there's any risk factors such as diabetes mellitus, long-term steroid chemotherapy, and any trauma to the skin, any recent instrumentation, any perineal wound, perineal blisters.
Okay. Yeah. Okay. Good. Right. So in the examination, how you can say this is? How will you differentiate this from just a cellulitis? Or this is a more than cellulitis?
So the sinister finding will be crepitus, the gas in between the subcutaneous tissue, can guide me whether it is more likely to be necrotizing fasciitis rather than the cellulitis.
And what do you think about the vitals? It will be the patient condition.
Vitals may be deranged in Fournier's gangrene rather than simple cellulitis. There is a scoring system, I think lower scoring system of Fournier's gangrene with vital signs.
Good,
to
right,
predict
okay.
diagnosis.
So now you are assessing him, and so from A&E, the medical board, they are saying his Q SOFA score is 3. So what do you understand by the Q SOFA score of 3?
SOFA score consists of respiratory rate, mental state, and I can't recall the other component.
Blood pressure.
Blood pressure.
So are you worried about this score of 3?
I'm not quite sure, sir.
Okay, so it's more than 2 or 2 or more it's very severe, right? So you said about this, and you said about this infection originate from that. Okay, so he was diagnosed to have a septic shock, and he's admitted to the HTU, and the Q-SOFA score was 3. Now, what is septic shock?
Septic shock is profound hypotension despite of fluid resuscitation due to defined focus of infection.
So, and his mean arterial pressure will be less than 65 despite the fluid transfusion, isn't it? Okay, so in this situation, what you had to give in addition to the fluid?
So I might need to give vasopressors and inotropes to pick up his to.
Okay, so in this septic shock, what vasopressor you will prefer?
I would go for noradrenaline.
Okay, good, right? So now, what are the investigation you will do? Of course, you do the bloods. Will you do a CT scan of the genitalia and pelvis?
CT scan would be better if the facilities are available to assess the extent of the involvement. But again, I would make sure that it does not delay the initial treatment of the proper surgical debris, which will save the patient's life. So after initial resuscitation and starting empirical antibiotic, I will prepare the patient for early debridement.
Right. So how are you going to manage this patient in the first hour?
So again, it is according to ALS protocol. So I will stabilize his vitals and then blood basic investigation and start antimicrobial therapy. Probably.
What do you understand by sepsis 6?
So sepsis 6 is we have to take 3 sample and give 3. Take 3 is blood culture, and we want to give IV fluids, IV antibiotic, and vasopressors.
Okay, so medical team already have done the arterial blood gas analysis, and the lactate level is 3. Are you worried?
Yes, lactate is high. So that is the third thing.
More than, what is the cutoff? More than what level they say is high?
I can remember vaguely 1.2. I'm not sure about that.
Okay, so more than 2 is high. So when the lactate level is high and high, what is the problem?
So it says there is metabolic acidosis going on. So it's due to hypoxia and metabolic acidosis.
Is it decide or is it predict the prognosis?
In
someone coming with the Fourniers gangrene, what do you think the average mortality?
Mortality is around 20 to 30%. So
does that mortality correlate with the serum lactate level?
And there is a scoring system, lower scoring system, which has SIR as a component of systemic inflammatory response syndrome as well as lactate also.
Good. So you have managed the sepsis 6, and you are going to take the patient to the theater, and the whole family is there. How are you going to get the consent?
So I will explain the condition to the relatives and the importance of early debridement, which can save the patient. So I will tell that the patient should rush to the theater with debridement, and then I'll make sure that the patient might return to theater again as well. And after that, end up in reconstruction in the future also. We need plastic surgical input also.
So what antibiotic you will give in this patient?
I already mentioned it's a polymicrobial infection. I would prefer gentamicin if there's no contraindication, third generation cephalosporin, and metronidazole.
Right. So what do you are going to do in the theater?
So after I make sure that the patient is prepared, and then I will debride the tissues, dead tissues, beyond the extent of the tissue, because there may be endarteritis which may go beyond the clinical extent till I see the fresh bleeding of the tissue. And then if the testes are exposed, I might need to bury the testis in the thigh. Testis is not involved in Fournier's gangrene because it has its own blood.
So do you expect the testis to get involved in usually commonly in Fonnius gangrene?
No, it will not, because it has its own blood supply from the aorta and it is not from the subcutaneous tissue. So in Fonnius gangrene, that is not involved.
Suppose if Fonnius gangrene, this patient associated with the periurethral abscess and the Fonnius gangrene, what is the additional thing you will do?
So when I drain the abscess, the urethra may be exposed. So he might need a suprapubic urinary diversion, suprapubic catheter insertion.
Right. So you said about long-term outlook, and you said about the Fonnius gangrene severity index. Any other adjuvant treatment? This is the last question. Any other adjuvant treatment which may be helpful in this patient other than surgical debris removal? I'm asking about post-surgical.
Hyperbaric oxygen or vacuum-assisted closure may increase the healing process and improve the outcome.
Thank you. Thank you. Time's up. Maybe, sir.
Yeah, I think Taha did a very good job. I think like reading a textbook, you know. So you don't have one in front of you, do you? Taha? You're not reading out of teleprompter. Teleprompter is not there either. So very good. I think I don't think if examiner asks about Fonnius gangrene, only thing is that some basics, you know, QSOFA scoring and then management of things you should not, you know, budge, because those are all very basic life support.
Yeah, again, sir, that
so,
sepsis 6.
That,
sepsis 6, please be clear. Giving 3 is IV fluids, oxygen, and broad spectrum antibiotic. Taking 3 is cultures, blood and urine, and ABG. You can't miss that. ABG. With that, serum lactate and other blood investigation, plus putting a catheter and taking the monitoring the urine out. Taking 3. So giving 3, taking 3. Sepsis 6, of course, you know, you have to tell that word and remember those things. Yeah.
Yeah, because I think those are sort of basic questions in life support. So apart from that, the theoretical part of Fonnius gangrene, he managed very well. So any other comments, Gobi?
Yeah, again, this will come in emergency and also will come in the infection. Again, your high chance you will get this one. So that's why I want to do this one.
Yeah. So I think you will get a clear path plus I think maybe. Yeah.
Anurudha sir,
Okay. Yeah, he did well. So good.
Any other things to differentiate from cellulitis, sir?
So one thing you said, the crepitus. Second thing is the pain will be out of proportion to the what you see. Second thing. Third thing, they say the patient will be very ill looking when cellulitis. Just they will have fever and things, but here will be patient confusion, hypotension. The clinical vital signs will be disproportionately dangerous level than what you see.
And there will be presence of gangrene, and there may be a demarcation of dead tissue from the normal tissues. In cellulitis, generally, it is a vague outline in the periphery. So, yeah. So, important thing is that you have to show that it's an emergency.
Yeah. So we have to talk like emergency, and we have to quickly tell things. Yeah. So I think today we had a good sessions, and three eminent Neville sir and Srinath sir and Priyan sir came, and thank you very much for experts and Anurudha sir. And Tirina, you can conclude the session with.
Gobi, I have a small question. Just for the benefit of the trainees, could you just elaborate on the benefit of the partial nephrectomy and the sort of long-term outcomes of the partial nephrectomy versus the radical nephrectomy? There is a sort of a concept of surgical CKD and medical CKD.
Yeah. So, so we were talking about partial nephrectomy. There's two schools of problem. Some people are saying partial nephrectomy preserve the kidney. No argument about it. But partial nephrectomy, radical nephrectomy, we do if we are doing in a fit patient, with a normal contralateral kidney, he is developing a medical problem due to CKD, and developing CKD is not common. Someone have already compromised kidney, then it's a problem. That is a one thing. So surgically made CKD better than a medical CKD. Medical CKD increase the heart problem and death, but surgically made CKD is not causing any heart problem like a medical CKD. That's a one argument. But we have to try to preserve more nephron as possible. That's for the partial nephrectomy. So if an old patient coming, better to do a radical nephrectomy considering this concept, and also making two complications. One is a bleeding and the urine leak and positive margin. So when we considering those problems, old people, you can go for a radical nephrectomy. But young people, of course, they can develop another tumor. They can develop diabetic later. So in young people, better to go for a partial nephrectomy much as possible. Of course, partial nephrectomy have a risk of developing a positive margin roughly around 8%. But again, they can ask how are you going to manage their positive margin. But that is not going to change the overall survival just because they develop positive margin. So you can conservatively manage with the imaging, then you can deal when the size become 2 or 3 centimeters. So they can go on like that. So anything else, Dr. Nishanta, regarding?
No, I think other things, and the other thing is the long, the series, all these prospective series, it still shows the radical nephrectomy has the survival advantage marginally over the partial nephrectomy. So just to know that, but on the flip side, we can say it has a comparable sort of survival benefit as the radical nephrectomy. So that's it.
I think when it comes to that, again, I think the initial, there's a large meta-analysis, and systematic reviews all shows that in the long term, partial nephrectomy and if you do a radical nephrectomy, the chance of getting CKD is higher. But that is the very reason why in the presence of a normal contralateral kidney, people start doing partial nephrectomies for the small renal masses. Because there is definite evidence there. There was definite evidence there. But recent meta-analysis have shown that if you go through some papers, that this rule applies only if your EGFR is less than 60. So over that, when you subanalyze the cohorts inside these large series, but they have found out that if the EGFR is less than 60 only, that advantage, long-term advantage is there of doing a partial nephrectomy. But if the EGFR is higher than 60, then of course there is no difference between radical and partial nephrectomy. But that needs, ultimately the conclusion was that it needs further studies to compare it, but all, so to prove it, but all at present, I think for all small renal masses, still if you go ahead and do a radical nephrectomy, because you don't have the facilities, so you don't have the expertise, you go and do a radical nephrectomy, there is a chance of litigation. But I think only though that last final, 2019, 18-19 papers would show that EGFR an effect on this long-term outcome of partial versus radical. Just read about a little bit.
Thank you, sir. And the other thing is on the management of the muscle invasive bladder cancer. Now, when somebody asks you about the what are the management options, is it better to put it as the radical cystectomy and a radical radiotherapy and a trimodal therapy as 3 different options? Because when you talk about the guidelines, some guidelines, they do mention about the trimodal therapy, and some guidelines, they try to sort of incorporate into the radical radiotherapy part. So is it better to sort of out as 3 main options, or what do you think, sir? Is it sort of, or you go for a surgery and radiotherapy as 2 different options?
Because I would go for argue for always radical cystectomy if it is a high volume tumor and high grade high volume tumor. Always argue for that, and especially involvement of the trigone and the upper tracts. So if it's a small volume tumor and it is low grade or low risk or low grade tumor, still muscle invasive, but low risk. Now, the risk classification is important when it comes to it. Then, of course, you can argue for a radical radiotherapy. But then the complications of the radical radiotherapy, you have to mention and say that downside to radical radiotherapy. But then again, trimodal therapy is also, there is a place for a very specially selected group of patients. Again, low volume tumors, and but when you are giving it, it has to be trimodal. So pure radiotherapy itself, I don't think has a place at all. So I wonder if you have any.
That's the thing, sir. In the EU guideline also, it has been sort of recognized as 3 separate arms, like radical cystectomy, radical radiotherapy, and the trimodal therapy as a special mode of treatment. So I think it's not very popularized in the other part of the world. Very, very small series are done for the sort of as a prospective studies for the trimodal therapy. So that may be the reason, I think, sir.
Yeah, I think it's better if you have got a sort of large tumor and muscle invasive tumor, always, as your own decision, you argue for radical cystectomy and try to show the downside of the other modalities. But if you are not making a decision, I think that doesn't sound well at this level of discussion. So always make up your mind and then argue for that, rather than giving options, because ultimately it will boil down to what you are going to do. Like, so always you can say MDT with the oncologist, radiation oncologist will discuss. But in this particular situation, my decision is that for these reasons, I'll be doing a radical cystectomy. The particular case was shown at the beginning.
Yes, sir. And there's another small question, sir. Now, let's suppose if there is a small tumor at the dome of the bladder, or maybe a small tumor inside the diverticula, which may be difficult to sort of amenable with the transurethral resection, is there still space for a sort of a partial nephrectomy or a partial excision of the tumor with the bladder and then to give a chemoradiation? Because some scenarios and some sort of guidelines mention about this, but I wonder what's your opinion on this?
Yes, I think that sort of a small tumor in the dome or a diverticulum, there may be a place for a partial cystectomy, but whether that's been given, especially if the random bladder biopsies are all normal. There's no carcinoma in situ, or rest of the bladder is entirely normal. And if it is a kind of a low-grade tumor, then of course you will have a place for that. But if it is a high-grade tumor, T1, G3, I think I can't think of any evidence to show that partial nephrectomy is going to be kind of an evidence-based treatment. But you and me know, I think both of us will feel stingy to get rid of the bladder in this sort of situation. So we will adopt a trimodal therapy where with a minimal tumor spillage, if you can do a partial cystectomy, preserve the bladder, and then give chemoirradiation. Long-term outcomes of this method has never been studied. I think I can't think of any study to show whether it has any adverse outcome in the long run, because the series are so small, this type of a treatment. But on an individual basis, I think you can take that risk, but not on principle, especially if it is a high-grade tumor. However small the tumor, you might decide to go ahead with radical cystectomy rather than partial cystectomy. Or else you adopt a trimodal therapy without breaching the malignant urothelium. You do a good TURBT and then send the patient for trimodal therapy. But then when it comes to a diverticular cancer, it's a different ball game. If it is again high grade and you can't say T1, D3 because there's no muscle in the diverticulum, so you can't classify that. So that has a poorer prognosis because the lymph node involvement is early. So I think you would rather go for a radical treatment because you can't do a safe URBT either, because there is a possibility of perforation of the diverticulum. So we all considered, I think a cystectomy will be the better choice for a diverticular cancer.
Yes, sir, thank you. I think the survival, cancer-specific survival was sort of very vaguely mentioned in various places. If it is a T2 tumor, for a radical radiotherapy, it is somewhere around 40%. And for a radical cystectomy, it's around 50 to 60%. And there are many series which quoting the trimodal therapy as in between, like 50, sometimes 50 to 80%. And there's no, as you said, so there's no good so prospective studies. But for the radical radiotherapy and radical cystectomy, apparently there are sort of good studies to quote those figures. So, thank you very much.
Thank you, Dr. Nishant. Thank you, sir. Yeah, Telina, up to you.
So that concludes our Uromet 17, the discussion on neurological oncology, second discussion actually. So I must thank Professor Neville Perera sir, Dr. Anuruddha Begunasekara sir and Dr. Balagopi for all the cases as well as the very important discussions, and especially Neville sir for all the valuable comments. I think these will be very valuable for all of our trainees and the candidates. So with that, we will conclude this session, and I think we will have a next session probably next Saturday, but as Professor Srinath Chandrasekhar sir mentioned, we might have some other sessions in between as well. So I think the academic committee will probably decide on what we are going to do during the next couple of weeks before the exam. So thank you very much once again, and thank you CIPLA for sponsoring all this, and see you all next time. Good night.
Thank you. Good night.
Thank you.
Good night.
Thank you, everybody.